Dear friends, we are going to discuss today anatomy of the vertebral column, starting by the subaxial cervical vertebrae. As you know, we discussed C1, C2 with the craniocervical junction, and we are here to discuss anatomy and injury of the subaxial cervical vertebrae. The subaxial cervical vertebrae have three common features. The canal is triangular in shape, and they have bifid spinous process, and they have transverse foramina, allowing for the passage of the vertebral artery, the vertebral vein, and the sympathetic nerves. So these are characters peculiar to C3 to C7 vertebrae. As you see here, we have a bifid spinous process, very peculiar for the cervical vertebrae. We have a triangular canal, cervical canal, and we have transverse foramina. Another view showing the body, transverse foramina, bifid spinous process, and the triangular canal. C7 is a bit different from C3 to C6. It has a long bifid, non-bifid spinous process that you can feel under the skin. The first prominence, if you go from rostral to caudal in the posterior part of the neck, you would feel a bony prominence. This is the spinous process of C7, and the foramen transversarium of C7 is smaller than those of C6, C3 to C6, because it doesn't transmit the vertebral vein, but only doesn't transmit the vertebral artery, but only the vertebral vein. So the vertebral artery, the vertebral part, passes from the foramina transversaria of C6 up to C1, but the foramen transversarium of C7 carries only the vertebral vein. And here is the difference. You find that it is a long spinous process, and it is not bifid, and you feel it under the skin. Also, the foramen transversarium is smaller than others, transmitting only the vein, not the vertebral artery. Another view. Canal, vertebral body, lamina, spinous process. And we talk about the joints. Joints of the subaxial cervical vertebrae is divided into joints common and present in the whole vertebral column, which is the facet joints, which is between the articular facets, as you all know, and the disc joints between the vertebral bodies and discs. And there is a joint peculiar to the cervical vertebrae, which is the ancovertebral joint, is unique to the cervical vertebrae. So about the facet joints, as we all know, we have all through the spine two facet joints in each motion segment of the spine, and they are situated between the laminae and the pedicle of the same vertebra. So the facet joint is lateral between the lamina and pedicle of the same vertebrae, and the inferior facet is the lateral continuation of the lamina. If you go laterally, you will find that the lamina became a facet, which is the inferior facet articulating with the superior facet of the vertebra below, and the facet joints are all lined by synovial membrane. As here you see a lateral view of a cervical vertebrae typical and the facet joints, and this is the inferior articular facet of the vertebra above with the superior articular facet vertebra below forming the joint, and here is the disc joint, and here is the posterior view of the cervical vertebrae. If you go laterally, with the laminae, you will reach the inferior articular facet, articulating with the superior articular facet of the vertebra below. Superior articular facet between the lamina and pedicle. Inferior articular facet is the lateral continuation of the lamina, and continuation of the lamina, inferior articular facet, articulating with the superior of the one below. Facet joints. Of course, it's different in C1 and C2. It is more horizontal between C1 and C2, allowing rotation of the axis over the odontoid process and, the atlas over the odontoid process of the axis. But C3 to C7, you find articulation between the superior and inferior articular facets. And the ancovertebral joint. Ancovertebral joint is a joint between a process called the uncinate process of one vertebrae and the body of the vertebra above. That's why it's called ancovertebral. And as you see, it has several functions. It guides and limits cervical flexion and extension. Second job, it reduces the side bending of the cervical spine, protecting the nerve roots. When you bend your head on one side, you don't compress the root because overbending is protected by the ancovertebral joint, and it prevents the translation movement between vertebrae, and it reinforces the posterolateral aspect of the intervertebral disc. So if you see here an anterior view, find the vertebral body and the disc, and when you go laterally of the upper border of the vertebra below, you find a process here called the uncinate process, and articulating with the vertebral body. And this is called the ancovertebral joint. Ancovertebral joint, as we said, prevents too much rotation and side bending and flexion extension. It also prevents translation, and it is reinforcing the lateral aspect of the disc. Another view, anterior view of vertebrae, upper border of the vertebrae, uncinate processes articulating with the vertebrae above, the body of the vertebra above, ancovertebral. This is an upper view, and you see it in the upper surface of the vertebra, upper border of the vertebra. And here is the lateral view showing the uncinate process, and anteroposterior view showing the uncinate process. Most lateral aspect of the vertebral body, upper border, articulating with the vertebrae above. And this is to show, to sum up, the joints and the ancovertebral joints and the articular facets and the discs. Talking about the ligaments, it's very easy. It is upward continuation of the dorsal or thoracic spine. You all know these ligaments. We have the anterior longitudinal ligament, posterior longitudinal ligament, ligamentum flavum, intertransverse ligament, supraspinous and intraspinous ligaments. In the neck we call it ligamentum nuchae. So you have a sagittal view of a cervical vertebra, and the ligament in front of the vertebral bodies is the anterior longitudinal ligament. Behind the vertebral bodies and disc is the posterior longitudinal ligament, and posteriorly ligamentum flavum is between the upper border of the lamina to below to the upper surface, upper third of the anterior surface of the lamina above. So ligamentum flavum is an interlaminar ligament, and then we have the intertransverse, the interspinous and supraspinous ligament we call the ligamentum nuchae. Another view, anterior longitudinal ligament, posterior longitudinal ligament, ligamentum flavum from the upper border of one lamina below to the upper third of the anterior surface of the lamina above, and here the interspinous and supraspinous ligaments in the neck called ligamentum nuchae. Called the same. The nerves of the cervical and the brachial plexuses. There is the cervical and the brachial plexus, and the cervical plexus. To remind you, there is a motor part and a sensory part, and the motor part, most important, C2, sometimes C3, and C2, C3 sharing in the ansa cervicalis, with the descendens cervicalis coming from C2, C3, and the descendens hypoglossi, which is C1, passing with the hypoglossal nerve and forming the ansa cervicalis, supplying the pretracheal muscles. Motor. Another important motor nerve is the phrenic nerve from C3, C4, and C5, and it is responsible for the movement of the diaphragm, and which means 80% of the respiration. Very dangerous nerve, very important nerve. And of course you have the sensory part of the cervical plexus, a great auricular, lesser occipital, transverse cervical. It's not that important. Some cutaneous branch, supraclavicular, and again descendens hypoglossi, descendens cervicalis, ansa cervicalis, and the phrenic nerve from C3, C4, C5, and the cutaneous branches, as we said, and the brachial plexus. You all know about it. It is, to remind you, it is formed of roots from C5 to T1, dorsal 1, roots, trunks, divisions behind the clavicle, and cords, the medial, lateral, medial, and posterior cord, and then we have the terminal nerves. We discussed it before, and we talk about the subaxial cervical spine injury now. You have to assume that cervical injury in any trauma is present in any patient with these 5 conditions. If a patient is coming from a high speed, high energy trauma, consider cervical injury. If a patient has Glasgow coma scale less than 9, so he is comatose, he can't express himself, also consider cervical injury. If the patient is conscious but having significant cervical pain, limitation of movement, or if he has severe neurological or any neurological limb or root division deficit, and cases with significant facial injury. So, coming from high-speed motor vehicle, not conscious enough to complain, having cervical pain, having neurological deficit, and significant facial injury. Any of the previous 5 conditions, the patient should wear a hard neck collar until he is fully investigated. Any patient with Glasgow coma scale less than 9 should undergo plain X-ray cervical spine, and on arrival to the emergency room, the patient should be submitted to the ASIA scale examination, which is full examination of the motor system and of the sensory system and the reflexes. And you can classify according to degree of neurological affection, what we call the ASIA impairment scale. ASIA A, complete loss of motor and sensory functions below the level of the injury. Including C4 and C5, S4 and S5. ASIA B is incomplete, where the sensation is preserved but no motor function. ASIA C, incomplete, where the sensation is preserved but the motor function is also preserved, but the power is less than 3, grading power, and Asia D, incomplete but motor function preserved and the muscle grade is more than 3, and Asia E is normal. So A, B, C, D, and E Asia. The sacral sensation is very important. Why? Because its presence indicates a better prognosis. Why? Because the sacral fibers are close to the pyramidal tract, and its presence indicates partial cord injury. So this is a cut section of the spinal cord. This is the pyramidal tract. This is the lateral and ventral spinothalamic tract of sensation. The cervical in the sensation and in the power is most medial, and the sacrum is most lateral, cervical, thoracic, lumbar, and sacral. And you find here the sensation also cervical, thoracic, lumbar, and sacral. The sacral fibers are the closest to the pyramidal. So if it is preserved, this indicates that the pyramidal might be in a shock stage and might recover later. And when to intubate is a very important question always asked. Should we intubate any patient with cervical injury? You should intubate any patient with respiratory distress. But do the plain X-ray before intubation if possible. If it is severe respiratory distress, don't wait, of course. And you do also intubation in any patient with cervical injury at C5 or above, because the phrenic nerve might be jeopardized, as we said, and patient, of course, with severe chest or lung injury, and cervical injury at C6, you might delay intubation if traction is decided. To have a conscious patient, we need to have the patient conscious where we are applying extraction. So if you are having a cervical injury at C6, you might delay intubation to do the traction with the patient conscious, with the patient moving the limbs under control before intubation and giving him general anesthesia. And of course, fracture at C7 usually doesn't need intubation. So these are the indications and the circumstances, what to do. Should we intubate? Should we not intubate from this? And another question often asked is when to remove the cervical collar, saying, as we said, any patient with the 5 conditions, we have to apply cervical collar. So when to remove the collar? Is it when you do a plain X-ray and it's free? When the CT scan is free, or both are not enough? So let's see. The accuracy of having nothing in the cervical spine by doing a plain X-ray is 62%, but with the CT is 99.9%, which means that the CT is the most accurate investigation, and if the CT is normal, remove the collar. So when the cervical plain X-ray is normal, don't take out the collar, wait till doing the CT to judge. But this is not underestimating the value of MRI. You should always also do an MRI to rule out if there is an associated disc rupture, if there is a hematoma or like hematomyelia or cord contusion. These things you only see by MRI. And we start the classification of cervical injuries, and many classifications are present. One of the old ones is the high energy impact in young patients, usually males, from motor vehicle accidents and sports, and low energy impact with an average age of 54, like falling on the ground, either just from the carpet or syncopal or anything. So you fall on the ground, you might have low energy impact. There is another classification according to the mechanism of injury, which is called the Allen-Ferguson classification. It is a bit old, but it was very efficient for years, and it's very simple. According to the Allen classification, we have either flexion, either extension, or vertical. Flexion with compression, flexion with distraction without compression, vertical with compression, and extension with compression or distraction. So flexion, vertical, extension. Flexion compression, flexion distraction. Extension compression, extension distraction. And vertical compression. So let's see here in flexion, here in extension, and here the vertical compression. The flexion with compression results in wedge, which is the compression fracture or teardrop fracture, and can have superadded posterior ligamentous injury, flexing the neck and having a heavy object on the skull, or jumping in a shallow water and you have flexion of the neck with load on the skull. Distraction without any load, severe flexion can occur with whiplash injury in motor car accidents, as we'll see, and the vertical compression causes burst or comminuted fracture, small pieces, also when having a load while the neck is in the neutral position. And of course, the extension compression, you can have disruption of the anterior longitudinal ligament. In severe cases, posterior longitudinal ligament is also disrupted, and extension distraction when you do severe extension without a load. One of the famous, when you intubate, difficult intubation, you can cause hyperextension of the neck, and this can result in injury if there is associated osteophytes or something like that, and even quadriplegia with little bony changes. And here is the Allen classification. And here, as we said, this is flexion, vertical and extension. You can get a distraction of the vertebrae. And radiology of the, let's see the flexion compression. Flexion compression causes compression fracture, what we call the wedge fracture, where the anterior border of the vertebrae is getting less than the posterior border. So this is wedge, and you can have here a part, maybe the teardrop fracture is also compression wedge fracture. The teardrop fracture, where a part of the vertebra is separated, like in here, and a piece of the vertebrae with wedging, and another teardrop fracture, small piece of the vertebrae. This is flexion compression or flexion wedging or teardrop, according to the mechanism or the severity of flexion. And in severe cases, we get compression with disruption of the posterior ligamentous complex. So injury in flexion, a load was applied, wedging of the vertebrae or teardrop fracture, with or without disruption of the posterior ligamentous complex. Flexion distraction, as we said, you can have severe flexion of the neck without a load on it, like in whiplash injury, severe flexion followed by severe extension, and this can cause dislocation or subluxation of the joints. Especially if you are wearing the belt. And you can get one facet dislocation, or both sides, as here. You see, this is normal, the facet above, inferior articular facet, and the superior articular facet and the joint. Look here, the inferior articular facet moved anterior to the superior articular facet of the vertebra below. It was supposed to be, this was supposed to be here, and in this case, complete dislocation led to locked facet. This is the locked facet. The articular facet moved totally in front of the superior articular facet of the vertebra below. It is locked. Or the best way to see it is do the sagittal reconstruction of the CT and paramedian, and you find this is a complete good relation. But look with this, the articular facet, inferior articular facet of the vertebrae above moved, but not to the extent of locking. If it comes here, it is locked, but here it is subluxated. So this should be here under this one, and it is subluxated. Look here, the relation, oblique facets, joints. Look here, it is moving in front of the superior articular facet of the vertebra below. And you can have unilateral facet dislocation. In unilateral facet dislocation, you have translation. You might have translation, but never exceeding 25%. And if it is more than 25%, it is bilateral facet dislocation. So the degree of translation depends on whether we have unilateral or bilateral facet dislocation. And this is an example. Unilateral facet dislocation, a translation movement of C4 over C5, not exceeding 25% of the vertebral body. And you can see here that it should be here, and this is a partial dislocation or dislocation in one facet. This is an example of bilateral facet dislocation. You get translation more than 25%. This is exceeding 50% or even 75% because the articular facet moved in front of the facet below, and this could be, look here, the relation. This is a sound relation, and this is the facet, locked facet. Now it is bilateral dislocation. You can reach severe translation. Bilateral facet joint dislocation, you can get vertebral dislocation also. Vertical compression, as we said, a blow on the top of the head or fall from a height in a shallow water, or you jump and you get neutral position and load. And this can result in compression and burst. The burst fracture, said the wedge is the compression fracture. The burst is the comminuted fracture. Comminuted fracture means fracture divided into pieces. So this is a wedge compression, and this is a comminuted fracture. This is a burst fracture. Same meaning. Another burst fracture, the vertebral body is divided into many pieces. This is comminuted fracture. Axial load in the neutral position of the neck. Like here, many pieces. And compressive extension fracture, you have a load applied on the skull while the neck was in position of extension. So you get disruption of the anterior longitudinal ligament, and in severe cases, even the posterior longitudinal ligament disrupts. This is extension with axial loading, and distraction, extension and distraction, as we said, a good example during difficult intubation. Another classification is the AO classification, 2013. It's a German classification. It's a bit complex classification, accepted in many centers, but most of the centers, as we'll see, are not using it regularly. So very easily, it's classification according to the bone, any fractures of the bony vertebrae is A. We describe tension band or the ligaments is B. And we describe displaced fractures, whether translation, whether rotation, whether angulation, is the displacement is C. So bony fracture A, ligamentous fracture B, displacement C. But extra items must be taken into consideration. F, to describe the facet joints, N, to describe the neurological status, and M, modifying factors. So A, we're talking about the bone, you can get A0, fracture appendages, spinous or transverse bones. You get A1, as we said, the compression or wedge fracture we talked about, involving the anterior part of the vertebral body. Remember, here we are talking about bone, just bone. Forget about the ligaments. And A2, if it is a split vertebrae, but not involving the posterior wall. Split into two pieces, not involving the posterior wall, is in place. And A3, it is incomplete burst fracture involving one vertebral end plate. You know that the upper and lower border of the vertebrae is called vertebral end plate, at the junction between the vertebrae and the disc, involving one end plate with comminution is A3, involving both vertebrae, it is a complete burst. So A0, fracture appendages. A1, compression or wedge fracture. A2, split vertebra. A3, incomplete burst involving one vertebral end plate. And A4, complete burst fracture involving both vertebral end plates. The tension band, talking about the ligaments, we're talking about item B. B is B1 is posterior tension band injury with partial physical separation of the bone, and it could be also anterior. So there is a partial separation of the bone in B1. B2, posterior tension band injury with complete separation of the bone and capsule ligamentous structures. And B3, anterior tension band injury with physical separation of the anterior structures. So B1 and B2 are related to the posterior tension band most probably. B1 with partial physical separation of the bone. Of course, when you injure the ligament, the bone will separate. So partial separation of the bone is B1. Complete physical separation of the bone and injury of the posterior ligament is B2. Anterior tension band, anterior ligamentous structure injury, anterior longitudinal ligament injury with physical separation of the anterior structures is B3. The translation injury, as we said, it is concerned with vertebral displacement in any direction. So A is subclassified, B is subclassified, C when there is any translation any direction, and the facet joints need special care. Also we have subtypes. F1 if it is a non-displaced facet with a fissure or fracture less than 1%, 1 centimeter the articular facet, or less than 40 degrees lateral mass involvement. So if it is a small involvement, there is a fissure in one of the articular facets, there is involvement of the lateral mass, some displacement, but less than 40% is F1. But if the facet fracture and it is stable, but the facet fracture is more than 1 centimeter injury, 1 centimeter fissure, or more than 40% of the mass involvement is F2, or complete injury of the lateral cervical mass, superior and inferior articular facets together, we call the floating lateral mass with fracture lamina and pedicle, because the inferior articular facet is a continuation of the lamina, and the superior articular facet is rising from the pedicle. So this is F3, and F4 if it is reaching the degree of subluxation or dislocation. So all the 3 parts, the joint is in place, whether with a small fracture, whether with a bigger fracture but in place, whether floating but in place, but once it is subluxated or dislocated facet or bilateral, it is F4. So we have A, bone, B, ligaments, C, translation, and F, concerning the facets. Also N, which is the modifications present. We talk about the essential is A, B, and C, but with some modification, we included the facets, F, and N, the neurology. N0, neurologically intact. N1, there is a transient neurological deficit that recovered. N2, radicular symptoms. N3, incomplete spinal cord injury. N4, complete spinal cord injury. And NX, which cannot be examined. Severe involvement, conscious level very bad, cannot assess the power, cannot assess anything. So you put NX. So neurological evaluation, AO classification. And modifiers, there is, if it is posteriorly capsuloligamentous injury without complete disruption. So sometimes you get posterior affection of the facet joints, of articular facets, ligaments of the anterior or cutting of the interspinous supraspinous ligament, but without complete disruption, M1. If it is associated with critical disc herniation, it is M2. If it is associated with stiffening, metabolic bone disease, like ossification of posterior longitudinal ligament, and vertebral artery abnormality. So some modifiers you can consider the displacement, associated disc, the quality of the bone, and what happened to the vertebral artery. You can add to the classification. So you can say, for example, this is a split vertebral body. This is an A2, and posterior band injury, we call A2, B2, and there is translation, A2, B2, C. And for the facet joint, it is a fissure less than 1 centimeter or less than 40% of the joint, say A2, B2, C, F2. It's a bit complex, but the Germans say it's very easy, so you have to trust them. Another F1, as we said, fissure with no displacement, big fissure or involvement of more than 40%, potential for instability, cut, totally cut from the pedicle and from the lamina. We have a floating facet, and F4 if we have complete subluxation or dislocation. For example, if we have fracture appendage is A0 and we have disruption of the anterior longitudinal ligament with B3, and there is a small fissure in the facet, it's F1. You understand the concept. I cannot give all the detail, but you should know that this is a relatively recent classification. The classification I prefer, the classification is more simple, is what we call SLIS classification, subaxial injury classification, and severity scale. The subaxial classification, injury classification, I love this classification, as we said, SLISC, subaxial injury classification. And it's very simple. It affects the morphology of the bone on category, whether it is wedge compression fracture, whether it is burst comminuted fracture, whether there is distraction of the vertebrae, whether there is rotation or translation. So compression is relatively stable. We take 1 point. Burst fracture, comminuted fracture, 2. Distraction of 2 vertebrae, 3. And there is rotation of the vertebrae or translation, movement 1, we take 4. And the dorsal longitudinal ligament, not the anterior ligament, if it is intact, is 0. If it is suspected to have disruption, it is 1. Or if you are sure it is disrupted, it is 2. How can you be sure? If you have widening of the distance between the spinous processes by the CT, so there is disruption of the ligament, or suspected disruption of the ligament, or intact ligament. The dorsoligamentous complex, it concentrates on the dorsal ligamentous complex, the supraspinous, the interspinous, the ligamentum flavum, and you get these. And third is the neurological status, as we said. If it is intact, it's 0. There is nerve root injury, takes 1. If it is complete cord injury, it takes 2. And incomplete, it takes 3. And there is, if it is persistent, you add 1 again. So how comes? Complete injury takes 2 because the hope of recovery is not good. But incomplete is more dangerous to interfere. You should interfere to save this cord. So incomplete, it takes 3. And the persistence of the cord injury, it doesn't recover, you add 1. In this case, 1 to 3 is non-surgical. 4, it is in between. You can take the decision for surgery or not surgery, but from 5 to 10, above 4, you should always interfere surgically. SLIS classification, subaxial injury classification, and severity scale. So again, bony, posterior ligamentous, neurological status. 1, 2, 3, 4. And dorsal longitudinal, discoligamentous complex, if it is affected, if there is involvement of the ligaments, involvement of the disc, if the discoligamentous complex is intact, it's 0. Suspected any disruption, anterior ligament, posterior ligament, but most probably posterior ligament, is taking 1. Disruption, it is taking 2. It is not suspected, it is sure. And neurological status, as we said. So this is a picture of a wedge compression fracture with intact, healthy posterior ward. and it is separated from the vertebral body, can call it teardrop fracture. And this is several pieces, as we said, what we call comminuted fracture, one piece, one piece, one piece, one piece, and the distraction fracture, which is the anterior disruption, anterior tensor band disruption, is the disco-ligamentous complex, as we said, and as we said, which is more frequent, the disruption of the posterior ligamentous complex. And how can you diagnose it? In the CT, there is widening of the space between the spinous processes, between the interspinous space is increased. Of course, you can see it with the MRI, but with the CT, you get this one. So these are the disco-ligamentous complex injury. And in this case, you get here severe dislocation of the spine. You get here wedging of the spine with some translation. So it's not, there is motion of one vertebrae over the other. And another translation injury is C4 with the disc mobile over C5, and this is dislocation. So this is cervical dislocation, as we said. The disco-ligamentous complex is complete disruption or severe disruption. So TLICS, we talk about the bone, we talk about the disco-ligamentous complex, and we talk about the neurological status of the patient. AO classification, we talk about the bone, A, we talk about the tension band or ligaments, B, we talk about the translation, C, we talk about the F, which is the facet, and we talk about the modifiers. Management, subaxial cervical injury, database evidence, World Federation, WFNS is the World Federation of Neurological Societies consensus. Subaxial cervical injury, SLICS, as we said, SLIS, is a safe and efficient classification that should be used, being easy for residents and surgeons. It's not my words. I told you I prefer the SLICS and SLIC, and also the World Federation prefer it. Why? Because it is safe, efficient, and easily used by residents and surgeons. But it's up to you to use SLIC or the AO or the old one of Alan Ferguson. Anyway, but you should know each of them so that you can use it according to what you are convinced with. Also the World Federation, SLIC, score more than 4, as we said, early surgery is needed, and surgery is also indicated cases of progressive, it's very logic. One patient has progressive neurological deficit and having a piece compressing the cord. So one of the indications for surgery, SLIC, more than 4, having progressive neurological deficit, having a piece inside the canal compromising the canal, and anterior surgery is indicated in the anterior column injury. If you remember the anterior column, anterior longitudinal ligament, and the anterior 2/3 of the body and disc. And additional posterior surgery, 360, is indicated in cases of multiple levels. You cannot rely on anterior plates only, or patients with severe dislocation or translation. We cannot rely only on anterior, or cases of severe osteoporosis and ankylosing spondylitis. So, the World Federation of Neurological Societies prefer the SLIC in conclusion. And surgery is indicated outside this if you have progressive neurological deficit, or you have a disc ruptured compressing the cord, or you have a canal compromise, whether by the disc or a piece from the burst fracture. And anterior surgery is indicated in anterior column injury. And should we add the second question, what to do, anterior or posterior? Always asked. Anterior surgery in anterior column injury, 360, anterior and posterior, cases of multiple level corpectomy, or patients with severe degree of dislocation or translation. You should not rely on the anterior plate, and cases, of course, of osteoporosis and ankylosing spondylitis. So this is the answer to when to do the surgery and whether to do it anterior or posterior. Also, the World Federation of Traumatic Locked Facets says that traction most probably helps in reduction and stabilization after that. It's you do the traction and you can reduce the locked facet, you can reduce dislocated facet. And in the majority of acute locked facets, anterior surgical techniques are sufficient with the traction. Traction reduce the locked facet. As we said, locked facet, the inferior articular facet of the vertebrae above passes in front of the superior articular facet of the vertebrae below. The inferior articular facet is the continuation of the lamina, and superior articular facet is rising from the pedicle. So if you can reduce it by traction, you can go and do an anterior surgical technique to stabilize it. But in chronic locked facets, patient coming after 2 weeks, and there is no disc prolapse, again, there is no disc prolapse, you can do the posterior approach. And you go, why posterior? Because to unlock the facet with a McDonald or a dissector, and you should always know locked facets is an emergency reduction, is indicated in cases of traumatic locked facets. There is a difference between locked facet, dislocated and subluxated facet. Locked facet means complete dislocation to the extent that I cannot reduce it. So traction and anterior approach. Chronic, go posteriorly and consider any locked facet reduction is an emergency reduction. There is another entity we have to talk about in cervical injury is the vertebral artery injury, and it is very important. Also, the World Federation said the vertebral artery injury after cervical trauma, you should do CT angiography. Is indicated in patients with blunt trauma near the course of the vertebral artery. So if the patient has a blunt cervical trauma, CT angiography is indicated, and if you find anything in the angiography, should immediately shift to catheter angiography and endovascular surgery or anticoagulation or antiplatelets. So CT angiography, and then if you suspect something, catheter angiography, endovascular surgery, or start anticoagulation and antiplatelets. When to do CT angiography in patient with head and cervical injury? There is a classification. One is called Denver classification, other is Memphis criteria and Denver criteria, which are very logic criteria. Let's talk about Denver. So if you have a hematoma in the neck, of course you should do an angiography. If you have a cervical bleed, if you have a focal neurological deficit not explained by the injury, and neurological examination is not consistent with the CT finding, it's not explained by the brain, or you have a stroke, of course you have to do an angiography, cervical injury followed by stroke. And the Memphis classification is more or less the same. But of course, if the patient is having Horner syndrome, Le4 fracture, which are severe facial fracture base involving the carotid, neck, soft tissue injury. These are the criteria where we should do an angiography in cervical injury, or any head injury. When to do an angiography, these are the risk factors, of course, associated Le4 1 or 3 fracture, because it's very severe fracture, and cervical spine fracture, fracture appendages, fracture dislocation, subluxation. It's logic to affect the vertebral artery, fracture base, and diffuse axonal injury. It is a severe injury with Glasgow Coma scale less than 6 and near hanging with anoxic brain injury. You have anoxic brain injury with, you have to do an angiography. So these criteria are done in cases of head trauma, not only cervical injury. But cervical injury is one of the risk factors for CT angiography. So should I do CT angiography in every case of cervical injury? No, but I should do it if it is having a hemorrhage or expanding hematoma, cervical brie, focal deficit, stroke that is arising, severe facial fractures, cervical spine fractures. Yes, you should do. If it is dislocation, subluxation, you should do an angiography. Fracture base, you should do an angiography. Glasgow Coma scale less than 6. This is very high risk. And anoxic brain, of course, you should do an angiography. Angiographic grading. There is a grading now for traumatic vertebral injury. And we are consisting on the vertebral because it is the artery concerning us in cervical injuries. Yes, carotid can be injured in cervical injury, but less commonly. Why? Because vertebral artery is inside the foramina transversaria, inside bone, in this region. Fracture of the bone can extend to the artery. So the grading is very logic. If you have dissecting aneurysm, this is very serious, the dissecting aneurysm, and it can cause dissecting hematoma. What is dissection? Injury to the intima, so that you will find a space between the intima and media where the blood can go and form a thrombus. So grade 1 of vertebral artery injury is when you have less than 25% vertebral lumen stenosis. Grade 2, if you have an intravascular Y after injury of the intima, after carotid of vertebral dissection, with more than 25 lumen narrowing. And grade 3 is pseudoaneurysm. And grade 4, complete vessel occlusion. And grade 5, vessel transection or major AVM. So after you finish the grading of the cervical injury, you do the CT angiography, and you have the grading. Is the vertebral artery patent? Yes, it's okay. But if it is affected, what degree of affection? 25% of the lumen is 1. More than 25% of the lumen is 2. Or pseudoaneurysm, what we call the pulsating hematoma. This means an injury of the wall resulting in blood contained in the tissues, continuous with the artery, so it is pulsating. And 4, complete vessel occlusion. We had complete occlusion of the vertebral artery. And 5, there is transection of the vessel. So these are the grading vertebral artery injury after doing the angiography. When to do CT angiography in patients with cervical injury, as we said, or head injury, as we said with Denver and Memphis criteria, before we said, like le 4, 2 or 3, severe injury of the face, or pulsating hematoma, or hematoma not pulsating, or breeze in the cervical region, or severe fracture base, or a Glasgow coma scale less than 6. You should always, a part of the test, you should do a CT angiography to save the patient early, as we said. And the angiographic classification, as we said, sorry, it's repeated, we have now the algorithm of management. So if I did this and I found vertebral artery injury, as we said, from grade 1 to grade 5, what to do? So blunt trauma, and you have the suspicion, as we said, Denver classification criteria or Memphis criteria are absent. You observe. Denver criteria or Memphis criteria are present, you should do a CT angiography. If there is nothing serious, you should observe. But if there is something serious, what is it? Is it grade 1 or 2, narrowing, or it is grade 3, the pseudoaneurysm, or it is occlusion of the vertebral artery, or grade 5, grade 4 occlusion, complete occlusion, and grade 5 is transection. So we have, after CT angiography, normal, observe. Abnormal, what type? If it is grade 1 or 2, which is narrowing less or more than 25%, you give medical therapy. If it is pseudoaneurysm, grade 3, you get medical therapy. If it is vertebral artery occlusion, you give medical therapy. Vertebral artery transection, you move directly to open surgical reconstruction. But medical therapy is the anticoagulants and antiplatelets. So if it succeeds, well, it's fine. The patient is not complaining, everything is fine. If not, you do the reconstructive endovascular surgery. That means you enter and you treat the vertebral artery dissection with a stent. You put a stent to prevent, if the medical therapy fails, you go, there is significant stenosis of the artery, more than 25, becoming 50 or 60%, progression of the symptoms of ischemia, medical therapy fails. So you give reconstructive endovascular surgery. So first you give medical, if it fails, reconstructive endovascular, and if you give medical therapy and you get pending cervical spine reduction at risk of thromboembolic sequelae from spontaneous recanalization, deconstructive endovascular surgery, you can occlude the artery if the patient can tolerate it. So whether you reconstruct the vessel, if there is progressive neurological deficit, didn't improve after medical therapy, and you can occlude this vessel if it is tolerated by the patient, by a balloon or something. And of course, if you have evidence of transection by CT angiography, you should proceed to open surgical reconstruction. So again, blunt trauma, Denver criteria, Memphis criteria, not present, observe. Present, CT angiography. CT angiography normal, observe. CT angiography abnormal, grading. 1 or 2 or 3 or 4, start medical therapy. Medical therapy, anticoagulant and platelets. 5, transection open surgery. But if you give the medical therapy in grade 1 or 2, grade 3 and grade 4, and you have the stenosis is increasing or the patient neurological deficit is advancing, you go immediately with endovascular surgery, reconstructive. If you have a thromboembolic risk and you have to manipulate on the vertebral artery during severe cervical injury, deconstructive surgery, endovascular surgery, which is the occlusion of the artery, thrombosing the artery to avoid sending distal embolization. And so in this case, if it is involving a dominant vessel, you go consider open surgical reconstruction, or you do the deconstructive, you occlude the artery. So what can do the neurointervention? It can reconstruct, it can put a stent inside this artery, or it can occlude the artery. And of course, surgical reconstruction is to repair the artery. So you can repair the artery surgically. If it is cut to ends, you cannot apply, has no role in the vascular surgery. But if it is partially affected, there is a tear in the wall, there is a pseudoaneurysm or something like that, you can put a stent and it will work. Thank you very much for your attention. And we talk too much about this subject, but I know it is a very important subject and nobody is taking it in detail. So sorry for being wrong, and hoping to see you next time with thoracolumbar fractures. Thank you very much and bye.